So just to let everybody know, we are recording this. It'll be sent and edited so that the pearls will live on forevermore in the internet. So I hope that's okay with everybody. So I'm not a massive fan of introducing myself at the start of talks, but I think my career probably illustrates where we've come from. So I'm a former GP, and I became a GP with a special interest in orthopedics in Shropshire in 2005 after passing my sport and exercise medicine diploma. And at the time, I walked into a horror show of vitriol from our local orthopedic consultants who thought that we were absolutely the worst people in the world, very dangerous. We're going to be missing lots of cancers, causing lots of harm to everybody. And really, it was a massive battle. A battle that probably, to a certain extent, unfortunately, still goes on to this day. But at the time, I don't think that orthopedic surgeons ever really felt that anybody else knew very much about musculoskeletal medicine. And that's really where we've seen a sea change over the past 15 years. Um, the second thing to mention is that I was a musculoskeletal commissioner for Shropshire CCG between 2016 and 2018. And we were looking at that stage to revolutionising the provision of musculoskeletal services within Shropshire, which is, unfortunately, from 2016 onwards, is still an ongoing process, although we are finally getting an alliance of the various groups within Shropshire to form a wider musculoskeletal service. And I've been a consultant in sport and exercise medicine, working in pretty much the same role I have been since 2005, since 2018. And I will talk a little bit about the role of sport and exercise medicine in musculoskeletal work. Right. So what's changed in 15 years? For me, the biggest change of all has been the absolute explosion of evidence base for conservative care. And if we're being honest, the explosion in evidence base for non-interventionist care. These are just two of the examples I gave when I became a commissioner. But Jeremy Lewis has published lots of evidence on the value of physiotherapy versus surgery for rotator cuff related shoulder pain. The evidence behind surgery for degenerate meniscal tears versus rehab is that rehab is just as good for most people. Same for spinal problems, same for elbows. The evidence base behind the sort of things that I do in injections has actually dropped away recently as well. And Twitter's been a big driver for a lot of knowledge for us. The problem being, to a certain extent, that what we are seeing in practice still lags behind what we see in theory. And one of the things I am keen to see is I'm keen to see nationwide the embedding of good quality conservative care for musculoskeletal problems. And I think tonight my drive for everybody will be to push for that. Now, unfortunately, I've got to press my buttons a number of times with this next screen because it's nicked from another PowerPoint. But this was what I was presenting to people in Shropshire about what a musculoskeletal service should look like. And I think there is widespread agreement roughly on what a good musculoskeletal service should look like. You need to have a point of access for everybody, whether that is a GP referral, an FCP referral, a self-referral. What people with musculoskeletal problems need is quick access to good quality assessment and treatment. And Amanda's going to talk about the FCP role in detail. And certainly FCPs were a glint in people's eyes when I first did this presentation. What's the baseline treatment for any musculoskeletal problem? Just about. It is good quality rehabilitation. It's about getting good quality messages early. It's about exercise. It's about decatastrophizing. It's about explaining about load. It's about taking a holistic approach to look at sleep, anxiety, depression, weight loss, lifestyle factors. It's about getting people moving and getting them confident that they are going to get better. And exercise and time are probably our best friends. And what happens at the moment is people come into the services far too late, by which stage they've got a lot of pain, a lot of catastrophization often. An integrated service in the second tier should include rheumatology, podiatry and orthotics, Occupational therapy, often underlooked. A musculoskeletal interface team, such as the ones that Giles and I work in. So anybody that's complicated and not responding to good quality evidence-based rehab should come in to see a team of skilled clinicians, a multidisciplinary team. So could be physiotherapists, osteopaths, GPs with extended roles, rheumatologists, sport and exercise medicine consultants, people who understand complexity, have the skills to deal with difficult patients, understand what rehab's been done, what rehab's been needed. Anybody who has good quality care in that service and doesn't get better should potentially move on to see somebody in secondary care. We need access to diagnostics, and we need access to a good quality pain management team for those in chronic pain. And what we forget is that actually a lot of the initial work can be done in fitness gyms and rehabilitation gyms by exercise professionals and strength and conditioning coaches. I haven't mentioned FCPs, and Amanda will correct that wrong, but certainly what a patient with musculoskeletal pain needs to see is somebody who knows something about musculoskeletal pain relatively quickly. So what is still needed? We still need to improve access to musculoskeletal specialists. And that is work that is happening now that wasn't happening 4 or 5 years ago. We need to improve the quality of rehabilitation that people get. You know, you don't take a day's worth of antibiotics, you take a course of antibiotics. And yet, we talked about consistency of messaging, about load management, about exercise, about reassurance, about the multiple factors that impact on musculoskeletal pain. We need evidence-based pathways. We need a specialist musculoskeletal MDT for complex and difficult cases, and I include myself in this, we need to consistently upskill the musculoskeletal workforce. That's all of us. AHP physios, AHP podiatrists, GPs, and consultants. We all need to learn from each other. I've got ahead of myself, but essentially what are we looking at in terms of true multidisciplinary working? I think musculoskeletal medicine is a really good case where there is a relatively non-hierarchical musculoskeletal multidisciplinary team. We've seen teams led by physiotherapists, by doctors, by orthopedics, by rheumatologists, and we've seen doctors working within those teams, not necessarily needing to lead them. But all those professionals have a role to play within multidisciplinary, non-orthopedic, non-surgical care. And Giles will be talking about the role of the GP with the extended role in that, which I personally see as a very important role. This Venn diagram that you hopefully see in front of you is not definitive. It was my brain dump last night in terms of the overlap we all have to just really show how our skills overlap and where that happens. So exercise and lifestyle specialists, sport and exercise medicine, the role of the AHP with extended roles in ultrasound scanning and prescriptions, GPs with interest in lifestyle, and GPs with extended roles all have a part to play and all can work together and learn off each other. So what does sport and exercise medicine specialists offer to the world of musculoskeletal? I have put a star in there because this is not about what I can do that somebody else can't do. So a lot of these things are interchangeable, but are seen in SEM consultants. So advanced diagnostic skills, and yes, physiotherapists can go and do advanced musculoskeletal ultrasound courses, and certainly I work with an AHP physio in my team who is far better than me at musculoskeletal ultrasound. So diagnostic ultrasound, advanced diagnostic skills. Doctors in particular, I think, are very comfortable with uncertainty. GPs in particular, and Giles will talk about this, are very comfortable with dealing with uncertainty and not over catastrophizing diagnoses, not worrying about having to scan everybody. We've got intervention skills. So I do ultrasound guided injections. I do unguided injections. So do many of my AHP colleagues. SEM doctors are comfortable within a multidisciplinary team. We work within multidisciplinary teams. I've worked in an MDT for the past 20 years or so. My boss in sport is a physiotherapist. I'm consultant lead of my own service. I work alongside my physiotherapy colleagues. one of the things that a doctor is acceptable to other doctors. That's not a great thing to have to say, but actually people often relax when they're talking to fellow colleagues. So I think having doctors involved in MDT, MSK teams is really important. Again, not alone in SEM, but we show leadership skills. That's the same for physiotherapists with leadership skills, with GPs with leadership skills. That's not a unique skill set. But we do have experience of working in elite environments, and bring the skill set of working with the elite into the NHS. And I'm really proud that I still work for the NHS as well as in elite sport. So I want to issue a call to arms to everybody tonight for collaboration between the big hitters, the governing bodies, the bodies within this field. So that's the Faculty of Sport and Exercise Medicine, BASM, the Primary Care, Rheumatology and Musculoskeletal Medicine Society, Health Education England, the CSP, Royal College of General Practitioners, groups like MSK Reform. What we need is political influence. We need to not be working in a patchwork way as we are now, with different companies setting up in different regions. We're all reinventing the wheel. I'm in the middle at the moment of reinventing the wheel in Shropshire, constantly phoning my colleagues elsewhere to see how they've done things, what are their pathways. There's brilliant work been done and it's patchwork, and we need to join together to push conservative, non-surgical treatment for musculoskeletal pain. The Faculty of Sport and Exercise Medicine, which is an accrediting faculty, is going to aim to push to become a Royal College of Sport, Exercise and Musculoskeletal Medicine. It aims to be a truly multidisciplinary organisation. I envisage that to have fellows and members, but also groups involved in primary care, musculoskeletal, AHP physios in musculoskeletal sport, and exercise professionals, all joining together to influence the government to continue to reform and improve musculoskeletal services in this country. And that is the end of my presentation. If you could save your questions till the end, I'm going to pop Amanda's up. And Amanda, if you're ready to talk in a second, I'll just get your presentation ready. So if I can just introduce Amanda Hensman-Crook briefly, and then I'll get her to tell you all the important things about herself and the work she's doing. But Amanda's a consultant MSK physiotherapist in primary care. She's a fellow of the Chartered Society of Physiotherapy, and she's currently seconded to Health Education England as their AHP National Clinical Fellow. She's leading on the training pathway, supervision and governance to first contact practice and advanced practice in primary care. So Amanda, over to you. I am in your hands in terms of moving a presentation along.
That's great. Thank you very much, Chris. And hello, everybody. Good evening. And thank you to BASM for inviting me to this forum this evening. Lovely talk by Chris. And I'd like to say that I'd like to continue the theme that I have a belief that MSK is one big family and we should all be working together. What I'd like to talk about is about a common standard of practice, which is what I've been working on. Would you mind popping on the next slide, because it's more interesting than the...
There you
go. Okay, so what I'd like to do is start from the very beginning in terms of Health Education England. You may or may not be aware that there's the development of the Centre for Advancing Practice in Health Education England. And what that does is it creates an ability for everybody to be able to run through a portfolio route to advanced practice multi-professionally. So when you look at the advancing practice pathway, you have an enhanced level of practice, which is level 6, it's degree level. And then you have an advanced level, which is level 7, master's level, and it moves through into a consultant level of practice, which is level 8, which is a doctorate level. As you can see with the diagram on the left, they're not separate bubbles. They merge into each other, okay? They cross over, so you don't just suddenly become be able to work at a degree level of practice to a master's level of practice to consultant level of practice, because it takes time to be able to apply your knowledge into practice. I'm going to be talking largely around the advanced practice pathway this evening. The advanced practitioners have 4 elements to them. So if you look at the diagram on the right hand side, you have clinical, research, leadership and education. They're not separate pillars of practice. They all interlink together and all of them inform one clinical decision, and that's really important. And when we're talking about an advanced level of practice, we're talking at level 7 at master's level. That's really significant because at master's level we're talking about people that are working with complexity, and that will become more apparent as I talk through there. If you have a look briefly again on the left hand side, you see that I've put FCP in the interlink between enhanced and advanced. Now the reason for that is it's not a level of practice FCP, but it sits at the baseline of the advancing practice pathway. So I'll explain that a little bit more from other slides, because it is a pathway to advanced practice. And FCP, because they work at a clinically advanced level, so if you like in the clinical pillar, they're working at MSc level, they aren't topped up to all 4 pillars of practice at level 7. But they're on the way. Can I have the next slide, please? So why set a standard of practice? So for me, being an AHP over the years, being quite long in the tooth now as well. So for me, it's been about different capabilities out in the system, because classically everybody's at a different capability level. And there's never been a standard of practice before across MSK, all of MSK. It's always been based on job descriptions and on bandings and local agreements and tick box exercises, which is all very nice, but how do we know that the practitioner can actually do the job at a standard of practice? So I've always wanted to be able to develop a core standard so that we can all sit together on that standard of practice moving forward. So why would we do this? Well, we want our patients to be safe first and foremost. Everything that we ever do is around our patients, and we want it equitable across the whole of MSK. So we've got one big MSK family, and also for the governance as well, to keep that goes back again in a full circle back to patient safety. So once you've got a core advanced practice capability at level 7, you're all working from the same baseline. So if you see my little dots around that say lots of specialities around it, that's all our superpowers. So even though we are all the same, we all have our superpowers, and we can all share our superpowers with each other if we all have the same standard and cross-fertilise with each other to raise the quality of MSK care across the whole board. So in terms of the advanced practice core skill set that we and capability skill set that we are setting in Health Education England at level 7 currently for MSK, it just means that everybody is on the same level playing field, and all the patients know what level of practice that we're working at, and we have the ability to look after them properly. Could I have the next slide, please? Okay, so I'm going to move on away from the whole of MSK, because advanced practice is obviously the framework is the advancing practice framework. It's out to consultation at the moment, and the governance that's wrapped around it is across the whole of MSK. But I want to speak about primary care specifically. So we ended up developing a specific primary care pathway to advancing practice, because in primary care it's different to working in the other sectors, because you're working with undifferentiated undiagnosed conditions straight from the street, whereas in the rest of the healthcare system you have filtered patients coming in often already. And also in primary care you're looking after the whole person, and I'd like to list all those things that Chris said before, which might be a bit boring if I do list them all again, but it's not just about the MSK, it's about environmental and social facts, about mental health, long-term conditions, frailty, complex comorbidity, polypharmacy. It's about being able to make sure that the red flags, MSK red flags, but also the visceral red flags are uncovered, and being able to spot really early presentations of not just MSK but non-MSK conditions, and to know what to do with them. So it's not just MSK, it's all the learning around it that makes the broad base that goes into it. So that's where the advanced practice is really important, where you've got all 4 pillars, because you've got an informed practice pulling it into the clinical pillar as well. So really, we need to look at the pathway from pre-registration degree, and what we're doing in Health Education England is focusing on student placements in primary care at the moment. It's really important that they're able to touch base right from the very beginning to understand the environment and to understand how MSK works then, and also to encourage them that when they go out into the ether in postgraduate education, they are able to maintain that broad base and see the importance of doing that rather than just being MSK centric, because as you move along into primary care, obviously it's really important to maintain that broad base of practice. So once you have done a minimum of 3 years in MSK out in the ether, and I'm talking MSK broadly, so in all AHPs, so podiatry and osteopathy as well as physiotherapy, but it's also applicable to all MSK if they can cover the right capabilities. They can then start the primary care training for first contact roles. So there's 2 ways to be signed off, if you like, to be a first contact practitioner. It's either via a portfolio route or by a taught level 7 HEI module. The only difference between the two, because the content and the capability document that sits underneath it, or the knowledge, skills and attributes document, which I'll touch on in a minute, it has all the same verification process in both things. So with the portfolio route, you'd have a supervisor who would verify each domain. It's not a tick box exercise. This is where you have triangulated evidence. And the stage 1 part that you're looking at here of the portfolio with the blue arrow at the top, the stage 1 part is the academic to advanced practice theory. So they sign off against all of the domains with triangulated evidence that is verified. And once that's done, plus these 2 e-learning modules, which are 8 primary care specific e-learning modules and 3 personalised care e-learning modules. Once that's all signed off, they can then move into primary care. When they're in primary care, for all you GPs out there and all you medics out there, you will be familiar with the RCGP work-based placement assessment. So it is aligned to that. So the RCGP have kindly allowed us to use the toolkit. And the reason for that is because we do want MSK in primary care to understand the level of practice that people are working on. If we're using the same as the GPs, then the GP trainers can then be involved in helping supervise, as can AHPs that have gone on a specific course, which we'll touch on right at the very end of this presentation. Now, all the elements and capabilities that are in the portfolio route sit within the level 7 module. The only difference between them is obviously the portfolio route is an equivalence route to level 7, but the TOR HEI route will give you an accreditation of a minimum of 20 points that can be used against an advanced clinical practice master's degree. So then they're a first contact practitioner. Now, there's 2 sorts, and I don't like talking about bandings because they're pay bandings, they're not recognised in primary care anyway, but because of the additional roles scheme coming in, we've had to differentiate between band 7 and band 8A. So what we're talking about, when the sign-offs happened, it's an entry level into primary care. So they are band 7s, and they're not advanced clinical practitioners. They're not signed off against the 4 pillars of practice to level 7, but they are signed off at that master's level clinically. When they go through the knowledge, skills and attributes document, which is the document that is the central core to the whole thing, they also sign off quite a few domains of the other 3 pillars of practice as well as. So what you end up with is that you end up with like a credential that is level 7 clinically, and then the other pillars are like topped up to a particular level, and there's a really explicit amount left that if you continue along a portfolio route, you can easily get across to the advanced level of practice across all 4 pillars of practice. And that's the 8A roles that are in the primary care DES. So going back to the knowledge, skills and attributes document, I kind of want to take a step back in history, if that's okay, if it's not too boring for people at this time of night. But how did we get to this point? So way back when I first came into post in health education England, and we knew that we needed to create a standard of practice across all the AHPs in musculoskeletal. We started off at the Chartered Society of Physiotherapy, and we got all of the special interest groups across the whole of MSK together. So that includes chronic pain, rheumatology, orthopaedics, trauma and urgent care, outpatient physios, the whole shebang. It all came together in a room, and we agreed on that meeting that we were going to use the international physiotherapy standards, the IFOMP standards, as the standard of practice across the whole of MSK in physiotherapy. That was really important because that was not recognised before. So the first time ever we actually had a standard of practice. Now the IFOMP standards are really significant because they've been cross-referenced against the primary care first contact core capability framework that is specific to all the other things that Chris had talked about and that I repeated that you need in primary care. So that sits within that framework. But the advanced practice multi-professional framework also sits within the IFOMP standards. So it was a very happy time when we realised, once the research had been done, that it all sat within there, because then we know that by using the IFOMP standards for primary care, that signed everything off really nicely within one standard of practice. So what happened then is we had formed a MSK partnership group and invited in the osteopaths and the podiatrists into that group. And we have ARMA represented and versus arthritis. And what we did in that group is we then got an agreement from the podiatrist and the osteopaths that they too would adopt the IFOMP standard of practice, because it nicely fitted in with everything, with the advancing practice and the core capability framework. So as long as they have their own governance structure, then those advanced practice standards will hold. So the next part of that, we needed to raise the IFOMP standards to UK standards, because they're international standards, and again, across the whole of the world, you can imagine that they're at different levels of practice MSK wise. So we needed to add in things like injection therapy, and like prescribing, and like so that it was raising it up to our advanced level skill set, or what used to be called extended scope practice. Next slide, please. Okay, so if you're looking at the whole thing for primary care, on the left-hand side, this is what we've just been talking about now, about first contact practitioners. So we're just going to concentrate on the left-hand side just to go over it, okay? So you've got two ways of doing it, just to recap: either portfolio route or a university taught module with exactly the same things in it. So the core to that is the core primary care knowledge, skills and attributes, MSK, which houses both the advanced practice standards and the primary care core capability framework within it. And then you've got stage 2 for the portfolio route. Whilst when they're in practice, they then sign off against the work-based placement assessment to prove that they can apply that knowledge into practice. That already sits within the HE module. When that happens, they can choose then to move on to stage 3, which is to become an advanced practitioner. So if you remember what I said, they already have a lump sum, if you like, signed off against the portfolio route to advanced practice in MSK. And they are then able to continue along the route for the explicit gaps of the domains that are missing, and then they can move through, and then they can have be verified against the rest of those domains, and then they can become an advanced practitioner in MSK. So if you look on the other side, it's going the other way around. So in terms of advanced clinical practice in the universities, we had this, there were lots of questions around, if it's an advanced clinical practice master's degree, why can't we just go into primary care? Well, it goes back to that undifferentiated, undiagnosed conditions. We want to be careful with them, making sure that they understand the primary care environment and the breadth of knowledge that's needed underneath it. So it's not just about the MSK, it's about the whole person and how to manage the whole person conservatively, and making sure they have the correct exercise and the correct rehabilitation program, and if they need to be referred on from an MSK point of view into any of the secondary care services or community care services for rehabilitation. So they too, if you've done an ACP Masters, you would still need to do the knowledge, skills and attributes training. And there's two ways of doing that. You can either, when you're doing the ACP Masters, you can either pull in the FCP level 7 module, which will knock off 20 credits for your ACP Masters degree, or you can just cross-reference against the portfolio route, the knowledge, skills and attributes, and then you're recognised as an FCP within primary care. And final slide, please. So obviously, if you're putting in a standard of practice, and that's going to be a governance tool to keep our patients safe, then obviously you need to make sure that the most basic form of governance is wrapped around it. So specific to this, as we call it, the roadmap, MSK roadmap into primary care, we have a 2-day training program that will be rolled out. The first ones will be starting via our professional SIGs, which will be open to anybody in MSK that wants to work in primary care. So they're starting in November and running, each of the 3 organisations will be running one supervision training session digitally, obviously, at the moment in the world that we're living in, per month for 5 months. And then by then they should be all set up in the PCNs. We're just sort of pump priming it at the moment to make sure that we've got the supervision. Day one's really about how you supervise a multi-professional team, because even though you are whatever profession you're in, then as an advanced clinical practitioner, you're supposed to be able to work multi-professionally and cross-boundary. So you can also supervise a wider MDT. So it's about that, and it's about how you look after them, and it's a bit of introduction to educational theory, what first contact practices and advanced practices, and differentiate between it, and meeting the trainee practitioners' needs depending on the level of practice. And of course their wellbeing is also really important. So that's just a background multi-professional piece. And then section 2 is about how you use the RCG toolkit and how you use the work-based placement assessment tools. So if you're a GP or a GP trainer, you don't actually have to do section 2, because you already know that, because you've been through it in primary care already. So you would just need to do session 1 just to make you comfortable with working. If you wanted to be a supervisor, obviously you don't have to commit to do that, but if you wanted to be, then day 1 would be really useful to you to understand how each of the AHPs work and what their own superpowers, like I talked about the specialty superpowers at the beginning, what they are, so that it's helpful to do that. So I would now like to hand back over to Chris, and then I think it might be Giles. Thank you very much for listening.
Amanda, thank you very much. Amanda, myself and Giles, and I think Dr. Richard Collins will be available too to answer any of your questions at the end. I'm keen to get all the presentations done. That was a brilliant insight into the work that's been done, particularly with advanced practice across all disciplines. Giles Cezanne is going to talk. Giles, are you going to share your screen and pop your presentation on while I natter away?
No.
Giles is a GP with a special interest in, or GPWER now, in musculoskeletal medicine. He works for Sussex MSK Partnership in Brighton. He's CCG clinical lead in musculoskeletal medicine for High Weald, Lewes and Havens. He's a clinical facilitator in Brighton and Sussex Medical School and a GP locum, and I'm going to be quiet and hand over to him now. Thank you, Giles.
Mm-hmm. Thank you. Okay, can you hear me all right, Chris?
I can, thank you.
Brilliant. I'm going to presume everybody else can. Okay, so welcome and thank you for having me on. I'm here to talk a little bit about GPs working in an extended role in musculoskeletal medicine, a little bit about the roles and perhaps some of the future direction of travel. My CV's changed a little bit since the one that Chris has spoken from. So just no, it's actually quite useful, really, in some ways, because that reminds me of some of the origins where I worked as a GP partner for a number of years, developed an interest in musculoskeletal medicine, and worked as a commissioner, as Chris did, for quite a while, for a few years, from 2011, involved in commissioning the local service, before actually then working as a GP with an extended role on what was called a GP with a specialist interest. Lots of different roles in education and development of interdisciplinary education as well. And I'm now was working in a mixture of spine and chronic pain clinics, and I do predominantly chronic pain clinics now. So that's me. Let me just get on. So the terminology alone is a little bit confusing, and it's probably worth just mentioning, certainly, that what do you get as a image in your mind when you think of a gypsy? Well, when I told my mother I was leaving a GP partnership to become a gypsy, I think she probably thought I was going in a very different direction. Certainly probably looked a little more like the second than the first picture, but the terminology is changing, and GPs with an extended role is the new phrase to use, and I will come on to specifically what that entails. But broadly speaking, again, what you'll see is a lot of overlap with what Chris and Amanda have already discussed, a range of different domains. But the one that I really want to pick up on is the role of the GP as what Richard Collins, a colleague of mine, coined the term the specialist generalist, which I really like, because like a lot of people with a specific clinical interest, what I found myself doing was developing more and more refined skills of various different interventions and diagnostics and clinical skills and assessment skills before realizing and returning to what is the core of what I do and what is probably the most useful skill, which is my training as a generalist. And musculoskeletal medicine is an area which particularly benefits from generalist skills. A couple of years back, I did a survey of a number of colleagues of mine who were all working at the time as GPs with a specialist interest, because what I realized is that we were a little bit of a directionless mob. There are lots of different traditional entry points to become a GP with a specialist interest, and as the name suggests, it's basically just an interest. It's something that you've got, often a little bit of background, done some previous surgical jobs, and people were sort of drawn into it, but with no single unifying organization, no single standard of practice. So quite a wide variety of practice of competencies out there. And I did this survey which asked a couple of questions I picked out to discuss tonight. One of which was, okay, so what are the common qualifications? Well, at that stage, and this is going back a few years, diploma in MSK medicine was the most common. Now, there were a few organizations offering those. The number of organizations offering those have diminished. But broadly speaking, you'd see people having some training in either sports and exercise or musculoskeletal medicine. But when I asked the question of what else do you need? What do you need as a GP with a specialist interest? There was a reasonably strong showing for people requiring more by way of peer support, updates, clinical guidelines, an opportunity to meet, and in particular, appraisal as well. So really looking to further professionalize the role. That's it. If we look at the context nationally, it's worth having an awareness of what's already been touched on by Amanda there, the primary care networks. All of this has come out of the NHS long-term plan that no doubt all of us have read through in great detail, digested. And just a couple of phrases I pulled out of the document that are relevant to what we're talking about here is the ethos of moving to more community-based care with an emphasis on generalist roles, expanding the MDT as Amanda's very ably discussed with us. But also within that talks about specifically to GPs, broadening of the scope of practice, developing credentialing, and interesting developments around things like fellowship roles, which allow for a secure employment of a portfolio role. So the actual workforce is changing, and I think the opportunities are being created if we can capitalize on them. Standardizing the accreditation and training very relevant to this is the standards that have been set by the Royal College back in 2018. And really, this is where we see the shift from GP with a specialist interest to GP with an extended role. A specialist interest is something, generally speaking, that would sit within a practice. What the RCGP in this document highlights is that a GP with an extended role is now moving on into a more defined role, which is not something that can be carried out without specialist training. It is not considered part of standard practice, and therefore needs the proper competency and accreditation to back that up. Now, the bottom right-hand box is really just describing the three sorts of routes in. So people like me already working in extended role, it may well be that there's a bunch of clinicians who may well have had training, may have got their membership exams in various different sites, who have then transferred into general practice. All those, and I know there's a few first five doctors on this, and parents of doctors training, who will be interested in possibly developing this as a role for the future. So what does that look like in practice? Well, you're going to have a nationally recognised standardised accreditation qualification of some sort. That needs to be backed up with a portfolio evidence and ultimately a structured reference. So this is all very familiar territory for a GP. You know, you kind of eat and sleep the workplace-based assessments. So it's really essentially a development of that ongoing. It's just a matter of capturing good practice. And what do we need to get us there? Well, we've got lots of little bits of this path that have emerged. So we've got some, you know, I think the standard set by the Royal College is fantastically helpful. We've got a governance framework now. There are a variety of different curriculums out there, but there is now a development of a curriculum which is very much going to be across the board. This is very much along lines with what Amanda's been developing with the rest of her team. So there's the development of a standardized curriculum, and the Faculty of Sports and Exercise Medicine has definitely put its mark in the sand and said they're going to support the accreditation of GPs and welcome, as Chris mentioned, allied health professionals into the family. So we're essentially building the home. Now, what we do from here will be supported by the development of this area of the GP with an extended role, with the suitable accreditation and examination that the faculty is developing, as well as the potential for membership of the faculty, a diploma membership. And again, as Chris says, this is not purely restricted to GPs, this is open to AHPs as well. And ultimately, what that's going to take us to is a place where we're going to see the support, development, accreditation, and ongoing professional development of each of these roles working in collaboration together. And I think a really strong basis for interdisciplinary working. So I think there's some really strong development happening. I think this next coming year should see a lot of this coming through to the fore. And I would hope that that has sparked some interest amongst you. Now I've got a funny feeling that is my last slide.
Thank you very much. But here we go. We've got the first question.
He was reading out the question: what's the difference between a first contact practitioner and a GP with a specialist interest or extended role? Do we need both? Go on then, Amanda. I'm going to throw you that one to answer first. I'll come in with my thoughts on that. Have you got an answer?
We need both. Yeah, even though we've got that lovely Venn diagram with all the overlap. We've all got a common standard of practice. Yeah. Remember, I went back to the superpowers. Physios, podiatrists, osteopath, chiropractors, whoever, they're not medical. They are not medically trained. And we will learn from the medics, things in the same way that they might learn something MSK from us. The GP SCRs will learn from us from MSK training. So it's about being able to share our knowledge together, but unless you're medically trained, you're not a GP and you can't do anything outside MSK and do all the things that GPs do at all. But you might be more specialised, say, for example, my area of speciality, or some of my areas of speciality is rheumatology. It might be that the GPs aren't. So Swings and roundabouts. So no, absolutely, we're not making a generic thing at all. What we're doing is creating a standard of practice that's a baseline.
It's interesting, isn't it? Yeah, I'd agree. I think it comes back to that Venn diagram, doesn't it, where each to their own. And I've been so lucky to work in very much the same as Chris mentioned before, that sort of MDT setting. So when I've worked alongside advanced practitioners, and that's been osteopaths as well as physiotherapists, the distinction is that they might come to me and we'll talk a little bit about prescribing, about and a big thing for me is comorbidity. So an area of interest for research for me is metabolic comorbidities in MSK health. That's when you're starting to go into lifestyle approaches, comorbid diabetes, there's a massive overlap in terms of multimorbidity. So there are definitely things that are well within the GP remit, which may be less common skills amongst the physio world. However, I was talking to one of my physio colleagues in the chronic pain clinic today. There's a skill set that the physios have that we don't. A classic example is being able to reproduce and modify somebody's pain in the room. It's such a powerful tool that physios are really, really good at. So yeah, it's an overlapping skill set, basically. But the best teams will need both, arguably. And that's also true for the SEM docs as well. They will have a different skill set again that will be different to my skill set, will be different to an AP's skill set. So we're better as a whole.
All capabilities will be the same.
Yes, yeah.
So I think the questions are few. This is great. I'm getting off.
Yeah, I'm seeing a few questions coming my way. Chris, do you mind if I dive into them?
I'd love you to, Giles. I was going to bring them into you. Certainly, I think in terms of the career in MSK medicine and GPWR in MSK medicine, that'd be a great starting point for us.
I'll try and rattle through them. So how do you develop your chronic pain interests? Crucial. Yeah, I mean, that is the single most valuable bit of whatever I've done. I trained to do spinal interventions. I trained in a whole bunch of other exciting bits and pieces, fancy whistles and bells and needles and drugs. The bit that is arguably the most useful is pain management. And actually some of the best teaching I've had in pain management has come from the physiotherapy world, the likes of Lorimer Moseley and others that you'll be familiar with. So there's some really great stuff. I've sought out various different courses. I've ended up teaching a bit on the Red Whale course. There's lots of really good courses out there. And one of the big pluses of the kind of collaborations that we're talking about is that doctors, GPs with extended role will get access to some of the courses that are available through organizations like the MACP, SOM and others. So yeah, there's lots of overlap and lots where we can help each other with the training. The questions about how you go, how you're working towards that, and the GP with an extended role. This is something that's being developed at the moment. What qualifications can you do? There's a few out there, but what I would be looking at is that this all has to be framed in the context of knowing that there is a competency framework. So hopefully what we're working to establish is going to be an overarching competency framework, which essentially is going to be the same as what Amanda's talked about. We're all working to the same standards. And what you'll find is different education providers will meet that. So it may be that, I mean, there's a master's course in Bradford, there's one being developed in Leeds, there's the SOM course, there's loads. There's not necessarily one single postgrad training course that's going to be the definitive course. There should be an entry-level standard qualification, which is what the faculty is developing. But the onus will be to have a portfolio of evidence that meets the competencies in the same way that Amanda's pointed out. Argue the most important thing if you're a GP trainee is do your GP training. So I wouldn't at the stage of a GP as a trainee be worrying too much about specialist additional education at that stage. Build the core standards, work as a GP for a couple of years, get your early years under the belt, get comfortable with being a GP, develop an interest within your practice, and then you can build on that, because it's those core functions as GP which will stand you in good stead.
And I would say reach out to musculoskeletal interface teams Reach out to your physiotherapy colleagues, shadow physiotherapists, shadow GPs in extended roles, get involved and get mentored. So once you are a GP, I do think GP is a wonderful base for then springing off into interest groups, particularly sport and exercise medicine and musculoskeletal medicine. I think it teaches you so many skills, time management, dealing with uncertainty, complexity, etc. Certainly as a doctor, I highly recommend general practice training. I'm just scrolling through the questions.
There's a couple of questions at the bottom, Chris, about the sort of the stems going in, you know, GP versus acute care. What are your thoughts on that?
I think I'm biased as a former GP. I'm very biased by that. I think in terms of training, a lot of people in terms of sport and exercise medicine do other things and then like to then have an interest in sports medicine, and I think that's fine if you're interested in pitchside care, etc. But in terms of the day-to-day care of an athlete, general practice, which is taught you to deal with mental issues, psychological issues, your musculoskeletal skills on top of that, and your interventionist skills, plus your time management and dealing with all these difficult issues that you have, I think is for me a core skill of SEM. So define what you want to do with sport and exercise medicine. If it's pitchside care, brilliant. If it's musculoskeletal, then I would suggest GP followed by sport and exercise medicine training or musculoskeletal medicine training with a diploma.
Yeah, it's certainly the viewpoint I came into it with was that as much as I love my sport, my rugby and so on, I was far too bloody lazy to go out on a Saturday and stand on a muddy touchline. And actually primarily what I was seeing as a GP and dealing with was not traditionally athletes. It was chronic pain, it was spinal problems. So that's what sort of took me more into the MSK sphere. There is massive overlap between both of them, of course. But yeah, as Chris says, the GP base was very handy. So I would certainly advocate for that. But then I would say that, wouldn't I?
I think we have our biases when it comes to this, and certainly as an SEM consultant, I probably am more sniffy than I should be at other professionals coming in and doing sports medicine part time. But I shall get over myself. I certainly think if you have a career, particularly somebody like Johnny Hansen up in Scotland, has a joint career as an emergency medicine specialist GP and a sports medicine specialist as well. Dane actually is in the chat just said also he's a big fan of GP training, and I think by experience it would be I can always tell the GP registrars who've done general practice. I think they tend to be the better ones. Ryan has put MSc in SEM or physiotherapy for MSK career. I wasn't sure that was an option for people. Amanda, do you have a feeling about, I presume, Ryan, that might be doctors doing masters in physical therapy. Is that a possibility?
I'm interested in that question actually, because my question to throw out is why don't you just become an advanced practitioner in MSK? Because that will get, and then you can maintain your own interest in MSK, but you'll still be coming to the master's level of practice, but you're tailoring it to yourself. That's the idea of having a portfolio route to advanced practice MSK, is that you can use your own MSK speciality, but you're still attaining the advanced practice level of practice.
And that's a great point, actually, is that a lot of the work that Amanda in particular has been doing, if I'm reading you correctly, and also the work that people like Giles are doing to try and dovetail the medical model within that, is that you should be able to pick and choose what suits you.
Exactly. It should be an individual choice, but with the same core of MSK practice in the centre of it. So Giles and myself and and Richard Collins, who I think unfortunately can't make it this evening, and another chap called Dr. Tim Noblet, who's not a doctor, he's a doctorate, he's a physiotherapist, and he developed the core capability framework for FCPs. We're all working together to see how we can align everything. So it should be easy for GPs with extended roles to be able to be all part of this and all go along together in a tailored kind of way rather than a one or the other kind of thing.
I know that Rifats, but excuse me, has there been a proposed pathway for a GPWER in sport and exercise medicine? And if so, how is it compared to the current SEM consultant pathway? I think the answer to that is no. We hadn't thought of that. I think essentially, we just have not thought of that at the moment. I think as a GP, your pathway would be a diploma in sport and exercise medicine, potentially doing the diplomat exam to join the faculty of sport and exercise medicine, and then working in integrated musculoskeletal teams, if that's what you'd like to do within the NHS, which would take you more towards the training that Giles and Amanda have outlined. It depends now, I guess, what you define a sport and exercise medicine doctor as, because it encompasses the roles of musculoskeletal medicine, exercise medicine, and sport and team care. And what I would see the faculty doing is developing exams and strands for each of those three elements of sport and exercise medicine, with membership and fellowship of the faculty based on passing exams for the whole of those three strands, if that makes sense.
Chris, can I ask you, with that in mind, because I would see that as being a question about destination as much as anything else. So yeah. I think anybody working as a GP with an extended role in the NHS, whether you put the label of SEM or MSK, you're probably going to end up going down the same pathway that I've outlined. But I wonder if they're referring to working as a GP with an interest in SEM, doing sports work, and there are a number of GPs working in not with the CCT in sports and exercise medicine, but they still do team sports and exercise medicine as well, don't they? But I don't know much about that. I mean, that's done very much by contacting a local sports team and seeing where the openings are. Is that right?
That's right. And I think, you know, we face a battle for SEM to establish ourselves within the NHS and within the sports world. So developing a sort of a bypass career that's not CSER or preferably CCT training now, I think isn't going to happen. So I think a career looking after sports teams will be at the moment experiential and mentorshipped. I think what we would like to develop at some stage is, just as we developed an MSK exam, knowledge-based exam, developing a similar exam in sports care. But I suspect that what will happen next is an exam in exercise medicine or an accreditation for the moving medicine program rather than team care, which I think is a rather more specialized area. Can I ask both of you, before we go, and please do add questions and put your questions in again if we missed you, but can I ask both Amanda and Giles where we think musculoskeletal practice will be in 5 years' time? I'm going to start off with you, Amanda, as you're driving a lot of the accreditation, but where do we see the bigger picture in 5 years' time?
In 5 years' time, I'm confident that we'll be joined as one big MSK family and that we'll have the same standard of practice in the middle of it all. And I would like to think that we'd formed a community of practice as a foundation to possibly a Royal College later.
Giles, similar?
Yeah, I think I'd like to see in 5 years that we've got better defined pathways. I think standardized care. I mean, I think it's all going to be there. And yeah, no, I'd pretty much map exactly what Amanda said there. So defined pathways, standardized practice based on community interdisciplinary working. And I think there's going to be, I think you will see, because the workforce in general practice is going to change. We know that's happening already. obviously COVID has spun everything up on its head, but I think we're going to see quite a different workforce in the future. I think we're going to have to accommodate people with portfolio roles. And I think that should be an exciting opportunity. And I think that's a way to create sustainable workforce. So GPs staying in GP as well as pursuing their specialist interests and extended roles as well. So yeah, hopefully my aim is you have a happier workforce at the end of it, that we enjoy our jobs even more than we do now.
So can I just answer the question below? Do I know if anyone's looking into how we can ensure the standard rehab within physio to ensure matching up to advanced practice? Absolutely. The advanced practice governance framework and the standards, advanced practice MSK standards, are out to consultation at the moment. Also, in terms of the primary care GP practice, on the 15th of October, the roadmap to practice is going to be landing into the system, and it will be tweeted to death, I'm sure. And so it's going to be a joint launch with Health Education England, NHS England, and the CSP. The only reason it's with the CSP and not with anybody else is because with the additional roles, obviously it's only physiotherapists that's part of that at the moment, but it applies to all of MSK. So watch this space. Should be landing heavily on the 15th of October.
Has anybody got any other questions? And while we're doing that, Giles, have you got any questions you wanted to ask to the group or bring up to the group?
No, I think we've covered quite a bit, and I can't see any other questions other than joining Twitter. Fizana, I think you're absolutely right. I find Twitter intermittently fascinating, educating, and wildly frustrating. So if you can have good application of filters and ignore the nonsense, there's some brilliant sharing of information guidelines. So if you're careful who you choose to follow on Twitter, for me it's a clinical thing. I don't use that, but it's a very good place to look. I think keeping an eye on things like BASM and the faculty events. Hopefully we should have more national interdisciplinary events forming as well. That's part of my aspiration. I've run a couple of conferences which have been great, getting lots of disciplines together. So we'll hopefully do more of that soon if we ever meet again, other than in pixelated form. There's a question here that's asking about, and Mary, I apologize. I think I did see that you asked this before about combining pediatric training with sports and exercise or musculoskeletal medicine. That's a really interesting one. I've probably the closest I've come to that is performing arts medicine, and there's a very good course in UCL contributed to by an ex-colleague of mine. That's well worth a look, because the performing arts stuff, there's a lot of dance, and that there seems to be quite a bit of pediatrics within that, given the cohort of performers. So that might be worth a look. Chris, Amanda, I don't know if you've had any other overlap with pediatrics in MSK or SCM?
In terms of paediatrics for HPs, we would have to do a specific paediatric course to work with paediatrics, or have recognised paediatric experience, because obviously you need to have a bit of a lower threshold with them.
I think orthopaedics have carved out pediatric MSK, partly because it's so dangerous and you might miss something terrible and all the rest of it. But actually, particularly if you have training in pediatrics, combining that with musculoskeletal medicine and running a pediatric musculoskeletal clinic would actually be a great thing. And we have some very good SEM consultants working in pediatric clinics, like Dr. Kim Gregory in Birmingham, for example. But actually, I think there is a gap in the market for that. Are most pediatric musculoskeletal issues operated on? The answer is no. So do we need an orthopedic surgeon to tell us that? I think the answer again is no. So I think that would be a good career move, and you could probably carve out quite a nice niche in that. Thank you for
And that's-
taking the time to see us this evening. I hope that's been informative. Do message us on Twitter or do contact BASM and we will happily answer. I am excited about the future. I am excited with the work that Amanda is doing. I'm excited with the work that Giles is doing. We are going to have, the next 5 years are going to be really good for musculoskeletal medicine. They're going to be collaborative. They're going to be respectful of each other's professions, and they're going to show all of us getting better and better at doing our jobs. So hop on board the train and contribute to keeping people healthy, well, and pain-free. Thank you very much for your attention tonight. And thank you very much to our speakers. Thank you, Amanda, and thank you, Giles, for 2 brilliant presentations.
Thank you.